All right. Thank you all so much for being here today. We are super excited to be able to put on this webinar and present during EMS Week. The theme for EMS Week is This is Our Community, and today we're going to be focusing our webinar on caring for our children. Even though we know this is a Save a Life Day, we hope that as aligned with that theme day, this will be an important topic. I'm Kathleen Adelgaze. I am the moderator for today. I serve with Rachel Alter as the co-lead for the prehospital domain at the EMS for Children Innovation and Improvement Center. And I'm super excited to be able to present at this webinar with Dr. Brian Moore, Dr. Sylvia Wusuansa, and Melissa Winger and Captain Maselli. We will also be hearing from Jeff Jarvis in a recorded presentation and Dr. Manish Shah in a recorded presentation as well. As we kind of move forward, next slide. Just a quick acknowledgement that the EIC is funded by HRSA and the Maternal and Child Health Bureau in a non-cooperative agreement. Next slide. So an overview for our presentation today. We're going to first hear from Dr. Brian Moore, who will cover a policy statement on pre-hospital readiness for children. And then following that, we'll hear from Dr. Sylvia Wusuansa talking about how that policy statement is put into action and highlight an important technical report that was also generated to support operationalizing the policy statement. We will hear in a recorded presentation from Dr. Jeff Jarvis on the importance of pediatric readiness for EMS agencies. And then we will hear from Dr. Manish Shah and Melissa Winger on the two key things that are being launched right now, our pediatric readiness checklist and our toolkit to support items on the checklist. And then finally, we're welcome to have Captain Steve Maselli from the Walton Fire Department in Kentucky to give a testimonial on being a pediatric emergency care coordinator. And at the end, we'll have some time for questions. Next slide. So just a few tips and tricks. Your microphones are muted, but please add any questions to the Q&A. We'll take some time to answer those Q&A between speakers and at the end of the presentation, should they come up. And then this session will be recorded and posted on the EMSC Improvement Center EIC website. Next slide. First, I'd like to introduce Dr. Brian Moore. Dr. Moore is a professor of emergency medicine at the University of New Mexico in the Division of Pediatric Emergency Medicine. He is also a former state EMS medical director for the state of New Mexico and the lead author on the joint policy statement. So thank you so much, Dr. Moore. We're super excited to have you here. Next slide.
Well, thank you, Kathleen, for having me. And I appreciate all the participants on the call taking time out of their busy day to get a little bit more information. I'm going to go over how we developed this policy statement and how a policy statement comes to approval. And then I'll also talk about what the actual recommendations in the policy statement are. Next slide. So a little bit of background on the policy statement. The policy statement is Pediatric Readiness and EMS Systems, a joint policy statement. This was started about 7 years ago in the American Academy of Pediatrics EMS subcommittee. The goal of the committee was to create a policy statement, and we had a few initial ideas, but we came up with an idea to model a statement after the 2009 Care for Children in the Emergency Department statement. And we submitted that statement to the AAP Committee on Pediatric Emergency Medicine. Next slide. So the first statement, the Care Children in the Emergency Department, was a collaboration by 3 national organizations. And we felt very strongly that we needed collaboration amongst those organizations, as well as NAEMSP and NAEMT. It was really the first time that such an undertaking with 5 national organizations was being tried. And we'll talk a little bit about the challenges with getting 5 organizations to all agree on language in a policy statement. Next. So it started off as a 17-page document. One of the things is that we had authors from all of the organizations, at least 1 or 2 authors from every organization. But it started off as a 17-page document, not including references. It was way too long as far as the partner organizations wanted it pared down to 5 pages. And then one of the organizations wanted it pared down to 2 pages. We didn't want to lose all the information that we had in the initial document. And so we included that in the technical report that Sylvia, that Sylvia will talk about after I'm done with my presentation. But there were significant negotiations and compromises with the authoring groups. This statement took over 5.5 years from design to publication. And at one point, I stopped counting, had over 120 revisions to the statement. There was a lot of give and take amongst the organizations, but the collaboration, and I think it was all worth it for the final product. In the meantime, as we were writing this, the original ED statement was also revised. Some of the language title change of this statement were adopted to align with the with the changes in the pediatric readiness ED statement. Next. So it's been published, co-published in 3 journals, and the recommendations in the statement is released in January of 2020. The recommendations is that the American Academy of Pediatrics, American College of Emergency Physicians, ENA, NAEMSP, and NAEMT believe that EMS systems should, next. And I'll go through the recommendations. They're obviously in the policy statement, and they're on this recording and will be on the website. But our recommendations were to make sure to include pediatric considerations in EMS planning and operations. That was also to support the NAEMSP position statement that came out while we were in the middle of writing the statement, to collaborate with medical professionals with significant expertise, to integrate evidence-based pediatric specific elements into direct and indirect medical oversight. Next. Also, as part of our policy statement, we wanted to support the EMS for Children performance measures that were also revised at the same time. So having pediatric specific equipment and supplies, develop processes for delivering comprehensive and ongoing education, and not just education, but evaluating psychomotor and cognitive competencies of the EMS providers, promote education about why kids are not just little adults. Next. To implement practices to reduce pediatric medication errors. These may include length-based tapes, pre-calculated drug doses, or verifying doses by another provider. We felt it was also very important to include pediatric specific measures in periodic QA and QI to address morbidity and mortality. We also want to support the NEMSIS system and recommended to submit data into a statewide database that's NEMSIS compliant. Next. Develop and maintain policies for the safe transport of children in emergency vehicles. This also helped to support the NESIMSO recommendations on safe transport of children. Develop protocols for pediatric destination with consideration of regional resources. And then very important is to collaborate with receiving EDs to provide pediatric readiness across the care continuum, which is part of the whole EMS for Children concept. Recommend including considerations of children and family in emergency planning and disaster, promote overall patient and family-centered care. This was important to also allow family members to remain close to their child during resuscitation, and to practice cultural religious customs as long as they do not interfere with patient care. Next. And last but not least, have policies and procedures to allow family member or guardian to accompany a patient during transport when feasible, and consider utilizing resources compiled by the EMSC program when implementing the recommendations above. Next. So wrapping up my piece of this presentation today, what are some of the lessons that we learned? Well, one of the things that when undertaking such a large policy statement is that you needed a champion in each of the organizations. And that's why it was very important to have one or two authors from each organization on the statement so that they could take it back to their organizations and really promote and see that it made it through all those committees. We also learned a lot about how each organization has their own processes for statements and approval. We learned also about how the different organizations have authorship, endorsement, and review. But the biggest thing, lesson learned out of all this is having to learn how to collaborate with others, collaborate with organizations, building bridges, and being extremely flexible. And there was a lot of times where you said, do I really want to die on that hill? And in order to get the policy statement, which I think ended up being an outstanding product, you had to be very flexible in the process. Next. So in conclusions of our statement is that ill and injured children and their families have unique needs that can be magnified when the children's ailment is serious or life-threatening. Resource availability and pediatric readiness across EMS agencies is variable. Providing high-quality EMS care to children requires infrastructure designed to support the pediatric patient and families. So therefore, it's important that EMS physicians, administrators, and EMS personnel collaborate with pediatric acute care experts to optimize EMS care through development of care models in order to minimize morbidity and mortality in children as a result of illness and injuries. Next. And I'd just like to acknowledge many of the other people that are presenting today are members of this statement. Could not have done it by myself by any means, and just an amazing group of people that were involved with writing, editing, and promoting this statement within their organization. So I just really like to thank all the people on this slide and then others that also reviewed the statement and the forthcoming technical report. Next.
Thank you so much, Dr. Moore. I don't see any open questions right now in the Q&A, but I think there'll probably be some at the end discussing some of the details as everybody gets a sense of what the policy report has done and where it's led to. And as part of that, we'd like to next introduce Dr. Sylvia Owusu-Ansah, who is an assistant professor of pediatrics at the University of Pittsburgh, also the associate vice chair for diversity, equity, and inclusion, and the pre-hospital medical director for UPMC Children's Hospital. She wears a lot of hats. She's also the author of the technical report, which was a large summary of the material generated for the policy statement that was whittled down. And in an attempt to not lose that information, a lot of that information went to the technical report. And she's going to go over some of the specifics about that. So thank you so much for joining us, Dr. Owusu-Ansah. We're super happy to hear from you.
Thank you, Kathleen. Thank you, everybody who has joined us. Thanks for the opportunity to share, to talk about the technical report. And so to know where we're going, we have to know where we come from. And so I want to talk a little bit about the background of this. The Institute of Medicine report released, many of you may be familiar with this, back in 2007, specifically recommended that EMS agencies designate what is called a pediatric emergency coordinator to ensure that training and guidelines are available to field providers to maintain competence in emergent care of children. That role, many of you are familiar with, is now commonly known as PECC, or Pediatric Emergency Care Coordinator. So the IOM report suggested that the individuals filling this role would serve as a resource to oversee several things. First, any pediatric care quality improvement initiatives within an agency, provide skill-based training to agency staff, and assure that things like medications, supplies needed for children are stocked and available in all responding vehicles. Next slide, please. And so, interestingly enough, almost about 7 years later, this has become a national impact in thinking about pediatric emergency care and how that can be merged with EMS. And so pediatric emergency care is recognized as crucial to the development and maintenance of pediatric protocols, education, and quality improvement. And so to go a step above and beyond the participation of the medical director and to recognize the specific needs of children in the EMS environment. This started as a research document led by Dr. Remick, Dr. Gross, again, Dr. Aldegues, many of the physicians here on this webinar with you today. And so those were some of the blueprints to the technical report that we'll be talking about right now. Next slide, please. So Dr. Moore nicely illustrated that we began with a very lengthy and meaty document, about 17 pages or more, that in collaboration with other organizations, we had whittled down to 2 pages in the means of a policy statement that focused on some of the aspects that we'll talk about today, as well as the recommendations that were previously mentioned. And so as to not lose the details of the recommendations that we had all worked hard to put forth, we kept we put it all in what's called the technical report, and we'll go over that in just a second. Next slide, please. So what is the essence of the technical report? You know, it is important for EMS agencies to have appropriate resources when it comes to special populations, which include children. Those things include physician oversight, trained and competent staff, education, policies, medications, equipment and supplies, and effective care. So the essence of the technical report is that it laid down the foundation to build optimal pediatric care within EMS systems, and more importantly, to serve as a resource. As we know, there's variability across all EMS systems across the nation. Next slide, please. So I'm going to take a little bit of a deeper dive here and talk about the key components of the technical report, which included sections such as the policy, procedures, and protocols, patient and medication safety, patient and family-centered care, pediatric safe transport, equipment, supplies, and medications, health disparities, mental health, interactions with systems of care, and special health care needs. When we think about children, we think about different means in the way of cognitive and psychomotor skills. So we delved into that within the technical report. When we talked about education, we talked about tools such as the Pediatric Assessment Triangle and the Prehospital Education Book in the way of PEP. I was very proud that we were able to integrate healthcare disparities in pre-hospital care as well as mental health. We know that these are highlighted issues that we are dealing with not only just 7 years ago when we started this, but very much now post-pandemic, and integrating systems of care within pediatrics and other adult care EMS systems. And in the way of medications, we know that medication dosing errors are a significant problem in the pediatric population. And so the technical report highlights many of these aspects of pediatric EMS care. Next slide, please. The technical report not only has national impact, but regional impact. Many of you may be familiar within your own states of collaborations and initiatives and where you're working within EMS agencies within your own states on pediatric emergency care coordinators within EMS agencies locally or within your own jurisdictions if you're not in a statewide based EMS program. And so a lot of the resources used are from the technical report. And so here I've highlighted some of the stamps that we've used in the state of Pennsylvania where I currently work. Next slide, please. And more importantly, moving the train forward. A national steering committee was formed where many of us here on this webinar are represented within that committee. and where we meet several times a year. And some of those members will talk more about the details of what we've been able to do post the technical report. Things that include checklists for EMS agencies and following suit of the EMS for Children performance measures. So it's now a national initiative that we are very proud to be a part of. Next slide, please. And when we talk about this national committee, it is known as the Pediatric Pre-Hospital Readiness Project Steering Committee, consists of numerous experts in pediatric pre-hospital care and EMS care, and again, a collaboration of EMS organizations throughout the country in various fields with various skill sets that are now putting the technical report into practice. And you can see here the list of different types of skill sets and folks that are involved in this project. Next slide, please. So in conclusion, the technical report helps to serve this purpose, as Dr. Moore concluded with earlier, that it is important for us as EMS physicians, administrators, and personnel to collaborate with pediatric acute care experts to optimize EMS care through the development of care models. Hopefully the technical report will serve as that in order to minimize morbidity and mortality in children as a result of illness. And thank you again for this opportunity to speak on the technical report.
Thank you so much, Dr. Owasonsa. I really appreciate your time and talking in detail about that, because it was a very heavy lift to kind of move the needle forward on that work. Unfortunately, Dr. Jeff Jarvis is not able to actually attend the webinar today, but we were super lucky to be able to have him do a recorded presentation, which we'll highlight next, where he speaks about the importance of pediatric readiness in EMS. Rachel, I don't think we can hear it.
My apologies, I was muted. I will try again.
Howdy, y'all. I'm Dr. Jeff Jarvis, and I am the Medical Director for Williamson County EMS and Marble Falls Area EMS in suburban Austin in beautiful Central Texas. I want to talk to y'all about the value of having a champion for pediatric readiness and the value of having a systematic evaluation of your systems to help you improve your pediatric care. Now, listen, I think all of us got into EMS, got into healthcare because we want to help people. And at the top of the list of people we want to help are our pediatric patients. We all want to make sure we are doing the best thing we can to care for our patients. One of the challenges when dealing with pediatric patients, however, is we just, compared to adults, don't see that many of them. Now, that infrequency is a good thing, again, because in comparison with adults, we just don't see that many sick or injured children. But the downside to that, the double edge of that, is that that infrequency means that we don't have the experience and we frequently overlook things and don't consider the care of our pediatric patients. We don't have the experience we need to get good with it. So how do we compensate for that? What is a great way of making sure we're not overlooking our pediatric patients? By doing two things. Number one is use a systematic evaluation of our education systems, our equipment, our protocols, our quality improvement, all of the aspects of our system. Use a validated tool to go through and say, do we have the things that we need to have in place to take great care of our kids? And then probably as important, if not more important, is have a single person who is a champion for pediatric patients. Having that champion has been shown again and again in the literature to improve outcomes for our pediatric patients. Have someone who is always there making sure that we are thinking about our pediatric patients as we build our systems. There are a couple of areas where those champions can really help. And I can certainly tell you in my system, We had a champion, Karen Haran. She came in, she used the evaluation tool from PEDS Readiness and looked at all aspects of our system using that checklist-driven approach. And she identified some areas that we needed to work on. Certainly, equipment was at the top of the list, and she really helped us focus on making sure that we had the equipment we needed to take care of the full age range of our patients. She helped us from an educational standpoint. Every year, we map out our educational curriculum or our schedule, and she was always there to advocate to make sure that we put in dedicated time to address pediatric issues. When we were revising our protocols, she did exactly the same thing. She helped us make sure we were not overlooking any portion of pediatric patients in our protocols and in our quality improvement efforts. We are very metric driven, and she made sure we adopted metrics to look at the care of pediatric patients. For example, we use one of the NMSQA measures to make sure that we are getting weights on all of our pediatric patients, and that we are, for our pediatric patients with asthma and wheezing, that we are appropriately documenting oxygen saturations, respiratory rate, and giving them the albuterol that they need. When it comes to weights and weight-based medications, we found that we were frequently making errors in these calculations, which isn't surprising considering the stress that we're under when taking care of sick kids. So we adopted a system where we would no longer do calculations. We would just look up the correct dose in an app on the phones of all of our paramedics. So again, pediatric care champions, incredibly important. Karen has been wonderful in improving the care we give to our patients, and a PEDS readiness checklist, something that allows you to evaluate your care in a systematic way. Great impacts to your care. Guys, thank you all very much. I really appreciate it. Y'all have a great day.
We're so lucky that he was able to take time to speak to the importance of pediatric emergency care coordination. And as I mentioned at the start, we're also lucky to have a pediatric emergency care coordinator be able to speak to their role, which we will talk about at the end of the presentation. Our next presentation is also recorded by Dr. Manish Shah, and I'll let him introduce himself.
Howdy, y'all.
My name is Manish Shah, and I'm a pediatric emergency medicine physician and EMS researcher, educator, and advocate based at Baylor College of Medicine and Texas Children's Hospital in Houston, Texas. I am a member of the National Prehospital Pediatric Readiness Project Steering Committee, and it is a pleasure to talk to you today about the EMS agency checklist. This checklist is one of the tangible resources that the Prehospital Pediatric Readiness Project Steering Committee has developed. It is based on specific content found in both the Joint Policy Statement and Technical Report on Pediatric Readiness in Emergency Medical Services Systems. The purpose of the checklist is for EMS agencies to self-assess the extent to which they are ready to care for children. By going through the checklist, EMS agency staff can identify specific short and long-term goals to equip their EMS agency to be even readier to care for children than they already may be. The checklist has been developed for all EMS agencies, regardless of pediatric call volume, because every 911 responding EMS agency has the potential to take care of a child. Based on a careful review of the content in the policy statement and technical report, our steering committee identified 7 domains to create the layout for the checklist. These domains are noted here. I will highlight key components of the checklist in each of these domains. For education and competencies of providers, our steering committee suggests that EMS agencies have processes for ongoing pediatric-specific education using one or more modalities, such as in-person lectures, online education, skill stations, or simulated events. They should include evaluating pediatric-specific competencies for psychomotor skills, which refers to hands-on activities such as bag mask ventilation, suctioning, and performing CPR. Cognitive skills are the core skills your brain uses to think and reason. Examples of these include use of the pediatric assessment triangle and interpretation of physical exam findings of acutely ill and injured children. Behavioral skills are interpersonal behaviors that connect to successful performance. Examples include providing patient-centered care, being culturally aware, and using principles of team-based care. For equipment and supplies, our steering committee suggests that EMS agencies utilize national consensus recommendations to guide availability of equipment and supplies to treat all ages, and have processes for determining competency on available equipment and supplies. For patient and medication safety, our steering committee suggests that EMS agencies utilize tools to reduce pediatric medication dosing and administration errors, such as a length-based tape or volumetric dosing guide, and have a policy for the safe transport of children, including the equipment necessary for the safe transport of children. For patient and family-centered care, our steering committee suggests that EMS agencies partner with families to integrate elements of patient family-centered care in policies, protocols, and training, including the use of lay terms to communicate with patients and families, having methods for accessing language services to communicate with non-English speaking people, narrating actions, and alerting patients and caregivers before interventions are performed. Policies and procedures should also facilitate family presence during resuscitation, the practice of cultural or religious customs, and allowing a family member or guardian to accompany a pediatric patient during transport. For policies, procedures, and protocols, our steering committee suggests that EMS agencies have pre-arrival instructions identified in EMS dispatch protocols that include pediatric considerations when relevant. Policies should also address pediatric refusals, consent and treatment of minors, and recognition and reporting of child maltreatment. Direct medical oversight should integrate pediatric-specific knowledge, and protocols should include pediatric evidence when available. EMS agencies should have a destination policy that integrates pediatric-specific resources, which may include consideration of regional resources and weighing the risks and benefits of keeping children in their own communities. For quality and process improvement, our steering committee suggests that EMS agencies have a process that includes pediatric encounters, that pediatric-specific measures are included in it, and that the EMS agency submits data to the state's pre-hospital patient care database, and that data is compliant with the current version of the National EMS Information System. They should also have a process to track pediatric patient-centered outcomes across the continuum of care, such as transport destination, emergency department diagnosis, and survival to hospital discharge. For interaction with systems of care, EMS agencies that are pediatric ready have ongoing collaboration with various sectors of healthcare. They have plans and exercises for disasters or mass casualty incidents that include the needs of pediatric patients, such as pediatric disaster triage and a plan for tracking unaccompanied children. They collaborate with external personnel or have internal staff focused on enhancing pediatric care by having either a pediatric emergency care coordinator, a pediatric advisory council, or a medical director with pediatric specific knowledge and experience. These EMS agencies understand pediatric capabilities at local or regional emergency departments for children that are having a medical emergency, traumatic injury, or behavioral health emergency, and they have policies or procedures for the transfer of responsibility of patient care at the destination. I hope that going through the content of the checklist has given you ideas about how to set goals for your own EMS agency to enhance its pediatric readiness. To equip you to succeed in reaching those goals, you will hear next about the toolkit the steering committee has created. You can learn more about the Prehospital Pediatric Readiness Project and the EMS agency checklist at the EMS for Children Innovation and Improvement Center's website by scanning the QR code shown on this slide.
Oh, we are so lucky to have him record those slides for us and go over such the checklist in such nice detail. And our next presenter is Melissa Winger. Melissa Winger is our Family Advocacy Network Advisory Network representative for the state of Minnesota, and also the mom of Devin, an amazing adult, young adult with complex medical needs. She is also the chair or co-chair of the Toolkit Committee within the National Pediatric Readiness Project Steering Committee, and we're really fortunate to have her present on the process involved in generating the toolkit. Take it away, Melissa.
Thank you. So looking at the subcommittee charter, to sort of get us centered on what we needed to do in terms of the report and the checklist, and to make sure that we adequately had enough resources to be able to complete the checklist to be ready for a pediatric patient. So our charter states the Pre-Hospital Pediatric Readiness Steering Committee provides leadership and mission definition for efforts aimed at improving pediatric emergency care outcomes and patient safety in the pre-hospital environment. The Pre-Hospital Pediatric Readiness Toolkit Subcommittee scope concentrates on addressing the identified pediatric readiness gaps within the pre-hospital environment and providing resources in the form of a toolkit to help EMS agencies align with the joint policy statement. I wanted to highlight our subcommittee members. This was an extraordinary effort to be able to collect all the resources in the pre-hospital environment. So I wanted to highlight our amazing team that submitted resources for the toolkit. Go to the next slide. And then towards the end of the project, we had numerous different resources. So I wanted to thank our fellows for joining us towards the end and actually reviewed the documents, sort of vetted what we had and able to figure out what we were missing, bring on some resources that we couldn't find. So I wanted to highlight these three amazing fellows that helped us with that. Next slide. So the process that we had, so we had everyone on the toolkit subcommittee team gather items. So we were looking at resources that were developed by state partnerships, by hospitals, by professional organizations, anything in the pre-hospital environment for pediatrics, resources that we knew about were submitted. So that ended up getting a lot of resources. And I think we ended up about 81 or 85 resources. And so we needed to figure out how to sort those, go through them, and actually match them up with different items in the checklist. And we also wanted to make sure that we had the most recent updated best practices and make sure they were relevant to the EMS community. And so then we organized into categories. And from there, we looked at different resources that would apply to different domains. So we had to kind of do a crosswalk and make sure that we had the right resource in the right domain. And so we ended up with about 60 different resources in many different formats to be able to be used by the EMS community. And so we wanted to format those on a user-friendly website. And so we ended up going live, if you want to go to the next slide, just recently. And so now this toolkit is going to be available on the website. So if you go out to the Pre-Hospital Pediatric Readiness Toolkit, the website's there, as well as the code that you can scan. It depends on your technical abilities, and you can choose which one you want to do. And it is available online. So we can go to the next slide. We'll talk a little bit how it's organized on the website. And what we did was we took a little bit of a deeper dive with the actual resources, because some of these, and especially this is just an example of the patient medication safety domain, but we were looking at sort of some of the policy resources, and they were quite lengthy, they were quite long, and so we wanted you to know what you were getting into when you were looking for resources. If you were looking for a video, if you're looking for a PDF format, and then how long is that document? So we also added the details, and you'll see in this example of what is there for patient medication safety. The ones that have details will actually kind of drill down into more specifics. So for example, we have a policy document, and maybe that's somewhere in like the 50 to 80 page range. We don't want you to have to sort through that. So we actually put in the detail section the page numbers that you would want to address. So it'll provide you a little bit more information so it can be used efficiently. So you don't have to sort through very lengthy documents just to get to the section that you're looking for. And also in the detail section, it will give you sort of the organization that put it together, the state partnership. So you have that as well. So very excited to be able to complete this toolkit process. I also wanted to highlight the fact that I am a family representative from Minnesota, and just to sort of acknowledge that in EIIC, the family voice is at many, many levels, and it's a part of everything that we do. And I want to encourage everything that the family voice can bring and help with what you are doing at a local level, that it is really going to make a big impact. So thank you to EIIC and for enhancing the family voice at all levels. Thank you.
Thank you so much, Melissa. That was wonderful. Thank you also, your leadership on getting that toolkit put together was incredible. Our last presenter before we are open for questions and among the panel is Captain Steve Maselli, paramedic with the Walton Fire Department. He is going to speak about what it means to be a pediatric emergency care coordinator. Thank you for being here, Captain Maselli.
Thank you, and I appreciate the honor it is I've been given to speak to everybody here today. I want to talk a little bit about us as a department, and kind of you'll see how this kind of feeds into everything I want to talk about here in the next couple minutes. First off, we are a smaller department. We're located in southern Boone County, Kentucky. We are just south of Cincinnati, Ohio. We operate out of 2 stations. We have 2 ALS ambulances that make all of our runs for us. Just kind of give you some numbers there. In 2020, we had 1,382 EMS calls for service, and we're kind of in the national average of 5 to 10%, with ours being 5.6% of those, or 78, which were pediatric calls. So we don't have a high volume of pediatric calls as some of the larger departments do. So this whole PECC has really been a huge positive for us and other agencies within, I can speak within the state of Kentucky as far as, getting us going in the right direction. We are fortunate. We are just about 30 miles away from a level 1 trauma center, a Cincinnati Children's Medical Center. So, not every agency has that luxury of being that close to a trauma center that can actually definitively treat, major injuries and illnesses of our pediatric population. Next slide, we can go to the video real quick. Thank you. So first thing I would like to do is I want to give thank Miss Morgan Skaggs. She is the our state's EMS for Children's project director, and she actually put together that video. And I spoke with her prior to this, and ask her if I could share, because I really thought, it sent a strong message and hit home about the importance of, what it means. And I apologize as they're getting a run right now. Give me just a second.
Dixie Highway, Berkeley Townhomes, Unit 1 for a 56-year-old female subject ill. Squad 91, 12665 Dixie Highway, Berkeley Townhomes, subject ill. I'm at 1446.
Okay, I apologize. I am at work, and we actually spoke about this very thing. I hope during my 7 minutes that we don't get a run, and of course it did happen. But anyways, getting back to where I was Miss Morgan Skaggs. She is our go-to person. She has actually put together a network within the state of Kentucky where all the agencies are in the process of appointing, PECC coordinators. I think it's a very good idea. It's really blossoming, and we're really going to go far in the state of Kentucky with this type of program. I can tell you I've been a paramedic for more than 20 years. In the past, we've just kind of got through our PALS training. That'll reset here momentarily.
91, you're responding 1447.
And we kind of got through our PALS training, and we kind of just kept our fingers crossed, and we kind of, if we made a pediatric run, we kind of, just hope for the best. And, over time, we've come to find out that that doesn't always lead to the best outcome in the pre-hospital care setting. So, organizations or the PECCs and how we kind of blossom in the pre-hospital care with children, we use various platforms here in the state of Kentucky that allows us to talk to other PECCs from different agencies. So we're a smaller run volume agency. I can speak with PECCs from, very rural agencies to other agencies that make a lot of runs. And we're able to get together and kind of share ideas and collaborate on different ideas that we work with. And Morgan kind of heads all this up and is kind of the focal point for these conversations. We've talked about equipment from what we use to transport pediatric patients to what type of training works best for everybody, as well as, protocols, what's the best protocol. We kind of are adopting a regional protocol here in this part of Kentucky. It's still in the process, and I think that's going to kind of help with our, kind of getting us in the right direction as well, because we're kind of all going to be training on the same, type of equipment, the same, we're going to all have the same ideas when it comes to pre-hospital care of pediatric patients. Next slide, please. Some of the things it has done for us here in our organization, we have adopted Hand Heavy. It is a very good pre-hospital pediatric program that kind of helps you as far as, working with children. It kind of gets you going in the right direction with children as far as, pediatric doses. It kind of takes some of the guesswork out of it, and it helps you kind of overcome some of those anxiety issues you may have, and kind of simplifies it for you. We've developed pediatric first in bags that are all inclusive. So if we get the pediatric run, we only have to take in one bag. We don't need to worry about what equipment is in this bag, what equipment is in that bag. We have it all self-contained in one bag, and our paramedics can, work 20, 25 minutes on scene with a pediatric patient out of one bag. It has allowed us to, obtain specialized equipment for dealing with pediatric patients. Again, through this network that we have created and that Morgan Skaggs kind of oversees. And one more fortunate thing that we're able to have is we're able here in our area and on our department, we coordinate training with the University of Cincinnati Air Care. They're also a level 1 trauma center basically for adults. They just happen to have a helicopter base right behind our station. And what we do with them is we coordinate training with them, and they come in with an extra set of eyes. We set up scenarios that involve children, and their helicopter crews and their flight physicians will come over, and they will kind of watch us as we, go through our scenarios or treat our pediatric patients, and kind of give us pointers. And that's an awesome tool to have, kind of getting those extra set of eyes on what's going on as far as, caring for children. And we kind of use that, those critiques to kind of guide our training and kind of get us to where we need to be as far as our pre-hospital care of pediatric patients. and I kind of run over a little bit, but I want to thank everybody for this opportunity to speak. And I could go on for a significant period of time and talk about some of the positives of a PECC and what it's actually done for us. But I'll open this up for any questions. Thank you.
Thank you so much, Captain Maselli. Right now, we don't have any questions in the Q&A. I might post some for some of our audience if needed, but for everyone, please put in any questions, Dr. that you may have for any of our presenters that are here today or about pediatric readiness for your community, your EMS agency. I did want to share with everyone that there is now registration is open for our PECC Workforce Development Collaborative. This is a collaborative being offered through the EIC, and the opportunity to register will allow for recruiting of pediatric emergency care coordinators for in the pre-hospital environment, for emergency departments. So it's open to nurses, other healthcare professionals, physicians, advanced practice providers, our state partnership managers, and specifically EMS as well. The focus will be across the continuum that we've just discussed on the role of the PECC, improving family-centered care and policies and procedures, giving some guidance on QI initiatives, communication across systems of care, and then also helping assess care team competencies, and then specifically, finally, safety issues around equipment, medications, and supplies. The commitment will be about 2 hours a month, and we're really hoping that this will be an interesting opportunity for those on this call today. We also do have a QR code, or you can register at that link. And I'm wondering if we can put the link into the Q&A for people to register, as that's an easily accessible way to do that. One question that was posed was asking for the link for the toolkit, and that is now in the Q&A as well. So people can click on that and it'll take you directly to the toolkit page. And you can see all the resources that have been uploaded there. One question I do have for you, Captain Maselli, is how has your role been affected by COVID and training and all of those other things for your agency? I know that so much of it has been kind of topsy-turvy for many agencies, but I was wondering if you could speak to some of the things that you strategized around to continue to stay pediatric ready in this era.
Yeah, I mean, it was challenging because we relied so much on hands-on. So we've had to actually kind of rely more on, the interaction with the other PECCs throughout the state through various platforms that we use to communicate and kind of get some ideas as far as training. How do we keep it going? How do we still make it effective for our crews, et cetera? So, and kind of using the, we've used Zoom quite a bit and Microsoft Teams. So it has helped. We've had some outside eyes looking in. It's a little difficult at times, but I think we've managed to, do the best we could under the circumstances we have been given. But, hopefully things seem to be slowly opening back up, and hopefully we can get to where we were pre-COVID as far as our training is, and getting more interactive with the, other agencies that we've worked with in the past.
Well, it's a huge effort. It really is a huge effort. One other question I have for Melissa, within the toolkit, are there any specific resources that are just for PECCs, or is it really for any and all users of the toolkit?
Yes, it is designed for anybody in the pre-hospital environment. And we tried to reach out to a wide variety of audiences. So medical directors, EMS, paramedics, anybody putting in policies, anything like that. We tried to cover the full scope of resources and who might be looking to get some help and some resources based on the checklist. So it is open, and we tried to get it to most audiences. And there's also another, it's not a final project. Things are being created. And so if there's different things that we kind of don't have a lot of resources for, different domains, things are still being created and worked on. And so there will be a plan to relook at that and update the toolkit going forward.
Wonderful. We have a couple of other questions. Is there an email I can follow up with in regard to assisting with proofreading and editing and gathering feedback via informational interviews to improve technical reports for regions, hospitals, or other projects? I'm wondering if Sylvia or Dr. Brian Moore, if you have any thoughts on that?
So yeah, let me just make sure I understand the question. So the question is regarding if there is any availability to edit or proofread or look at technical reports, maybe locally or jurisdictionally. Am I understanding that correctly? Or?
You know, I believe so. Although I now realize that that I think that question is directed towards the EIC. And so, Dr. Remick, do you have any thoughts on that?
Sure, we can provide an email address into the chat box that can be used for follow-up.
Okay, thank you so much. So actually, Dr. Wiswansa, would you speak to the inclusion of the PECC in the technical report and how we kind of chose to work that issue within the checklist?
Yeah, so I believe, so the PECC is a critical aspect to what we do. Well, due to Kate Remick's work and Dr. Gaushay Hill's work and many of the folks who worked on pediatric readiness within the emergency departments and within the hospitals, we realized how essential it was to have a pediatric advocate within our emergency care systems and including EMS. And so the PECC works as a nice hinge to that. Some of the aspects and the difficulties in the EMS area or agencies as opposed to the hospital environment is who could serve as a PECC, right? So in the hospital environment, we may have more in the way of pediatric advocates or experts, but we realize that in the EMS agencies to be very flexible, those who are gung-ho about taking care of kids and willing to advocate for them would best serve in this position. And it really, with the data that we've seen nationally from the pediatric emergency preparedness work, there's been lots of improvement from the hospital environment in having a pediatric advocate or PECC available. And we're looking for that to be the same in the EMS realm, just needing to be a little bit more flexible in the means of when we think about geographic areas, rural versus urban, and things of that nature, and the resources we have available to us.
Yeah, that's very helpful. That's very helpful. It doesn't look as though we have any other questions. I think those that have been submitted have been answered. Do any of our panelists have any final words you'd like to say?
Just thank you again. I've appreciated this, and it was really, I enjoyed it. And speaking, I'm continuing to learn every day, and I think this is really a good opportunity to, progress pediatric care, especially in the pre-hospital field.
I just have one comment, and that is being it's EMSC week. I do want to thank all of our EMS providers and anyone that has taken care of patients like my son on behalf of the family. I truly feel like my son wouldn't be doing well and actually even survive today if it weren't for the EMS that have helped him throughout the years. So just thank you.
I want to second Melissa. Thank you. Thank you. All of our EMS providers, first responders, fire service personnel for all that you do every single day beyond this week. So thank you.
On behalf of the other panelists and myself too, one, thank you very much for all you've done. I hope that this week has been an opportunity for you to see how valued you are in our communities and thank you also for joining us to hear more about pediatrics and pediatric readiness for EMS. And we hope that the resources we've shown you will be useful to you as you work with your agencies to prepare for that. And I think we will end here. Thank you guys all so much for participating. I really was lovely to hear everyone's presentation.